Neoplasm coding is not about memorizing cancer codes. It's about understanding the behavior of the neoplasm, the site, the sequencing rules, and the intent of the encounter. And once these rules are clear, ICD-10-CM Chapter 2 on neoplasms stops feeling complex. It becomes logical, almost predictable. In this masterclass, I'll guide you step by step through Chapter 2, Neoplasms, exactly as outlined in the official ICD-10-CM Guidelines for FY 2026. No shortcuts and absolutely no confusion. If you're a new medical coder, this session can genuinely change how you understand and code cancer diagnoses. Chapter 2 of ICD-10-CM covers codes ranging from C00 through D49. This chapter includes all malignant neoplasms, most benign neoplasms, and neoplasms of uncertain or unspecified behavior. However, there's an important detail every new medical coder must understand. Not all benign neoplasms live in Chapter 2. Some benign tumors, such as prostatic adenomas, are classified in body system-specific chapters instead. That's why the first rule of neoplasm coding is simple but critical. Always confirm the behavior of the neoplasm before selecting a code. Behavior comes first because the correct chapter and the correct code depend on it. To code any neoplasm, there's one step you can never skip. You must first determine the behavior of the neoplasm. Ask yourself, is it benign? Is it in situ? Is it malignant? Or is it of uncertain behavior? And if the neoplasm is malignant, your work doesn't stop there. You must also identify whether there are secondary or metastatic sites involved. Missing this step doesn't just affect code selection, it leads to wrong sequencing, claim denials, and increased audit risk. Behavior and spread define the code, and they define coding accuracy. Here's an important neoplasm coding rule that many new coders miss. When a primary malignant neoplasm overlaps two or more contiguous sites, ICD-10-CM instructs us to assign the .8 code, known as the overlapping lesion code, unless a specific combination code already exists. Now, pause here because overlapping has a very precise meaning. It applies only when the tumor crosses the boundaries of adjacent, touching sites, not separate, not distant. On the other hand, when a patient has multiple tumors in non-contiguous sites, for example, tumors in different quadrants of the same breast, these are not considered overlapping. In those cases, each site represents a distinct tumor location, and ICD-10 requires you to assign a separate code for each site. Remember this rule: touching sites, use overlapping. Separate sites, code each one. Let's talk about malignant neoplasms of ectopic tissue, a rule that can easily be overlooked if you're not careful. When a malignancy arises from ectopic tissue, it must always be coded to the site of origin, not the site where the tumor is discovered. For example, if ectopic pancreatic tissue becomes malignant and involves the stomach, the correct code is still pancreatic cancer, because that is where the tissue originated. In neoplasm coding, location matters, but origin matters more. Using the neoplasm table correctly is one of the most important skills in cancer coding, and it always starts in the alphabetic index. Never jump straight to the neoplasm table. The index tells you how ICD-10 wants you to think before choosing a code. If a histological term such as adenoma is documented, you must look up that term first in the alphabetic index. This step helps you determine the correct behavior of the neoplasm and directs you to the appropriate column in the neoplasm table. Once you've selected the correct column based on behavior and site, your work still isn't finished. You must always verify the code in the tabular list, checking for greater specificity, instructional notes, and any additional coding requirements. Skipping these steps is what leads to errors. Following them is what separates professional medical coders from beginners who rely on guesswork. Let's walk through the admission and encounter guidelines for neoplasm coding, because this is where sequencing accuracy really matters. When treatment is directed at the primary malignancy and the cancer itself is the reason for the encounter, the primary cancer is assigned as the principal diagnosis. However, there is a very important exception. If the encounter is chiefly for chemotherapy, immunotherapy, or radiation therapy, the focus of care is the treatment, not the cancer. In those situations, you must assign Z51.0, Z51.11, or Z51.12 as the first listed diagnosis, with the malignancy coded as a secondary diagnosis. Now, let's look at treatment of a secondary or metastatic site. When a patient has a primary malignancy with metastases and treatment is directed only at the metastatic site, the secondary malignancy becomes the principal diagnosis, even though the primary cancer is still present. Remember this rule: what is being treated today determines sequencing. Now let's talk about complications associated with neoplasms, because sequencing here follows very specific and very testable rules. We'll start with anemia due to malignancy. When a patient is treated only for anemia caused by the cancer itself, the malignancy is sequenced first, followed by D63.0, anemia in neoplastic disease. This is a key exception in ICD-10, and it's intentional. But the rules change when anemia is caused by therapy. If anemia results from chemotherapy or immunotherapy, the anemia is coded first, followed by the malignancy, and then the adverse effect code T45.1X5-. If the anemia is due to radiation therapy, again, anemia is sequenced first, then the malignancy, followed by Y84.2, indicating radiotherapy as the cause. Now let's look at dehydration. When dehydration due to malignancy is the only reason for treatment, the dehydration is coded first, with the malignancy sequenced second. And finally, surgical complications. When a patient is treated for a complication following surgery, the complication itself is always sequenced first. Remember this guiding principle: sequence what is being treated today, unless the guidelines clearly tell you otherwise. One of the most important distinctions in neoplasm coding is the difference between a current malignancy and a personal history of malignancy. If a malignancy has been completely removed, there is no further treatment directed to that site, and there is no evidence of active disease, then you should assign a Z85 personal history code. However, if any treatment is still ongoing, whether it's additional surgery, chemotherapy, or radiation, the condition is not history. It is still coded as a current malignancy. This distinction is critical because history codes are never used while the cancer is still active or being treated. Also remember this important rule: history codes apply only to former primary cancer sites, not to secondary or metastatic sites, with only limited exceptions defined in the guidelines. When in doubt, always ask, is the cancer still active or is it truly in the past? Let's review a few special neoplasm situations that require extra attention in ICD-10-CM. First, disseminated malignant neoplasm. Code C80.0 is used only when there is widespread metastatic disease and no known primary or secondary sites are identified. It should never replace specific site coding when that information is available. Next, malignant neoplasm of unspecified site. Code C80.1 should be used rarely and especially avoided in the inpatient setting whenever possible. Now, consider malignancy in pregnancy. When a pregnant patient has cancer, assign O9A.1 first, followed by the appropriate neoplasm code. For pathologic fractures due to neoplasm, sequencing depends on the focus of care. If the fracture is being treated, M84.5 is sequenced first. If treatment is directed at the neoplasm code comes first. Finally, for malignancy associated with a transplanted organ, sequence the transplant complication code from T86 codes first, followed by C80.2 and then the specific malignancy code. In every case, let the reason for the encounter guide your sequencing. Let's close with a couple of rare but high-yield exam topics you should always remember. For breast implant-associated anaplastic large cell lymphoma, assign C84.7A or C84.7B depending on remission status, and do not code this condition as a complication of the implant. And when lymphoma spreads to solid organs, you do not assign secondary organ malignancy codes. Instead, use the appropriate extranodal lymphoma code. These rules appear rarely, but when they do, they matter. Neoplasm coding isn't scary. It's structured, logical, and completely rule-driven. Master these guidelines, and you master ICD-10-CM Chapter 2. If this session helped you, you're already thinking like a professional medical coder. Like, share, and subscribe to Coding Doctor, where ICD-10 is explained clearly, confidently, and the right way. Thanking you for watching this video. Bye-bye.